Welcome everybody. Thank you all for attending. My name is Tim Devling. I'm the Director of Sales and Applications here at iThera Medical. And obviously I want to welcome you here today for both attending and taking the time to come to this webinar on imaging of tumor function and response with optoacoustics. This will be a summary of research just published in Nature Biomedical Engineering by the group led by Dr. Jan Grimm at Memorial Sloan Kettering Cancer Center in New York. The webinar itself will last for about 40 minutes with times for question at the end. Should you have any questions, you should be able to see that you can extend or expand the go-to webinar box, and there's a questions tab in there where you can type in your questions and we'll get to them at the end. We'll also be recording this webinar and we'll send you a link to that soon after this broadcast. So we welcome today the lead author on the paper, Dr. Katja Haedicke. Katja studied for her master's in 2010 from the Friedrich Schiller University of Jena in Germany, where she then also obtained her PhD in the lab of Professor Ingrid Hilger, and she worked on both photodynamic therapy and tumor vascularization before heading to New York as a postdoc, where she most recently returned to Germany and joined iThera as an application specialist. So I'll hand over to you, Katja, and I hope you all enjoyed this webinar.
Yeah, thank you very much, Tim, for this nice introduction. And also from my side, hello to everyone and welcome to this webinar. And I'm really happy about this incredible interest in this webinar and the topic of optoacoustic imaging. So we actually just 3 weeks ago got this paper out in Nature Biomedical Engineering, and I would like to show you what we did in this work and how we got there, and introduce to you high-resolution optoacoustic imaging for visualizing tissue response to vascular-targeted therapies. So how did this actually all begin? It's a story which started in Germany, as Tim already said, as I did my PhD in the lab of Professor Hilger in Jena. And then I got the offer to join the lab of Jan Grimm at Memorial Sloan Kettering Cancer Center to start there as a postdoc and also continue my work on photodynamic therapy. He already had a collaboration with the Weizmann Institute of Science in Israel, the group of Avigdor Scherz, and they are huge experts in vascular-targeted photodynamic therapy. So I went there for a few weeks to learn how to do this treatment. And then we also got in connection or had the collaboration with the Institute of Biological and Medical Imaging in Munich, as well as the Technical University in Munich with Vasilis Nitsa-Christos. And they are engineers and experts in setting up these optoacoustic imaging systems. And of course, then also we got joined by other groups from Memorial Sloan Kettering Cancer Center, for example, from the urology department. So I went to MSKCC and started my postdoc and started working on RSOM. So RSOM, this is the modality which I used for this study, and it stands for raster-scanning optoacoustic mesoscopy. So I shortly introduce you how this modality works. What you do is you have a mouse that's under anesthesia and you place it in a warm water bath. Then you fix the tumor of the animal with a thin plastic wrap just to get rid of breathing motion during the imaging. And then you have a scan head, which comes from above into the water. It consists of an ultrasound detector and laser fibers, which are illuminating the tumor tissue. So the tumor is illuminated with a 532 nanometer laser, which is a perfect wavelength to excite hemoglobin in the blood vessels. And then basically you illuminate the tissue, the skin or the tumor tissue with a very, very high pulsed laser. In this case, it was 2 kilohertz, meaning the laser pulses 2000 times in a second. And the so-called optoacoustic effect then leads to a short thermoelastic expansion of the tissue due to the laser light absorbance of hemoglobin, especially in the red blood cells. And this leads to formation of ultrasound waves in the tissue. So we can detect the vessels by detecting the ultrasound waves. This, what was used for the RSOM is a 50 megahertz transducer, and that allows for detecting a bandwidth of 5 to 80 megahertz. So it's a very broad ultrasound bandwidth that we can detect. And with that, you can detect vessels of a diameter of 15 to 240 micrometers. So you can already see that even very small vessels can be detected. And all of this, of course, it's non-invasive. So you can image tumors over time, several days, yeah, very long time without interfering with the tissue. What do we get from this modality is images like that. So what you see here is a CD26 colon carcinoma tumor, which got implanted subcutaneously under the skin. And then you can detect with RSOM ultrasound frequencies from 5 to 80 megahertz. And what we do is also splitting up these frequency bands into higher and lower frequencies. So the lower frequencies from 5 to 25 megahertz in this case, they show bigger vessels, and higher frequencies from 25 to 80 megahertz show smaller vessels. So just based on the frequency of ultrasound waves, you can distinguish smaller and bigger vessels. So these are color-coded here in red and green, and in the following slides, the colors will always refer to the different frequency bands, and in yellow you see the overlaid colors, and that means vessels of intermediate size. What you also can always get is a 3D image of the vascularization, and this allows for really detailed insight into tumor's vascular network. So you can look at it from all directions and do a 3D quantification of the images. Just as another example, here another image, which is really nice, of a CD26 tumor showing a very complex vascular network with very fine vessels of different size. Just so you get an idea how also different tumor models look. So for the paper or for the study, we basically got stuck to CD26 colon carcinoma tumor, so the one you can see on the left side. But if you look at different tumor models, you can really get very specific characteristics from these models, and each tumor model has its own very specific features. So for example, the second one, these Allen-Capps prostate carcinomas, they are very bloody. You can see this already in the animals, and they show huge areas of low frequency signals, meaning the red. So this is how you detect it in RSOM. And then the 41 breast cancers, they are rather smaller tumors and show very, very small blood vessels. And then on the right side, the RINCA, the renal carcinomas, they have a fine network also of vessels. So each model has very specific characteristics. So RSOM can detect them and distinguish them and then follow them also over time. So the first thing we did using RSOM was to follow tumor angiogenesis during tumor growth. And here you see a CT26 tumor which got implanted under the skin. And you can see starting from day 0 that there are barely any vessels. What you see in red is mainly the skin vessels. But then starting from day 3, you can see already an intricate network of very small vessels developing. That's why you see them in green, because they are rather small. And then going on with time, the vascularization becomes more mature. You see more branched vessels, and it's much more chaotic. And at day 17, you really have a complex network of vessels within this tumor. To see how much we could actually detect with RSOM, the first thing we did was visualizing vasoconstriction by placing the mouse in the water bath and then imaging it, and then injecting adrenaline, which is a vasoconstrictor. And as you see in the images here, especially in the lower row, these zoomed in images, that vasoconstriction could really be imaged in individual vessels, especially 1 minute after adrenaline injection. So if you compare the first image with the second one, you can see that some vessels constricted and got smaller, and they changed their color from rather red-orange to green, showing that they emit higher frequencies and therefore meaning they got smaller. Continuing with time, they dilated again and got bigger because the effect of the vasoconstriction was gone, and then they almost reached the size from what they had before. You can also see the quantification on the right side, so you can really measure single vessels and their diameter over time. So with RSOM, we could detect very small and early changes in this vascular network. In the next step, in this collaboration with the Weizmann Institute, we wanted to study vascular-targeted photodynamic therapy. So I will explain in a second how this therapy works. But basically, yeah, they already had some experience on this treatment, but the detailed mechanisms are still not discovered. So we thought of looking into the tumor vasculature during or after this treatment. So how this therapy works, it's already also approved in the clinics in some countries for prostate cancer. But basically you inject a photosensitizer intravenously. So this it's a light activatable substance which distributes within the blood vessels in the whole body. And then you take a specific laser. In this case, it was a 753 nanometer laser, and you illuminate only the tumor area. And this leads to an excitation of this photosensitizer, which then can transfer the energy to oxygen within the tissue. And that leads to the generation of reactive oxygen species, and they are toxic and then destroy the blood vessels and the surrounding tumor tissue. So what we did is we used RSOM to monitor the tumor vasculature, and then we did the treatment with 9 milligram per kilogram heliporphin, which is also known as Tocat soluble on the market. And then we immediately afterwards illuminated the tumor for 10 minutes and followed the vessels and the behavior of the vasculature over time with RSOM. The first image is the therapy effect in a rather smaller colon carcinoma tumor. And what you see here in the images is different layers of the tumor. So the first one on the top is at 350 micrometer deep inside, where you can over time after treatment see that the signal intensity increased, which showed that there was clotting inside of the blood vessels. Then inside of the tumor, where you see bigger vessels before treatment, you can see that already at 10 minutes after treatment, these vessels got occluded and the blood flew out into the tissue, and we can detect hemorrhage. As you see on the second picture in the second row, which again rather shows up as a low frequency signal in the images, so a red signal here. And then also if you go deeper inside or lower, you can also see that the tumor feeding skin vessels got destructed or destroyed with time. And of course, this also can all be quantified. For example, the hemoglobin signal in the low and high frequency channel, as you see here, this correlates very well with what you see in the RSOM images. We then looked at more mature colon carcinoma tumors, so meaning they were a little bigger and they had a more like a stronger vascularization. And as you can see here in the images, that already at 5 minutes after therapy, certain vessels got really occluded and destroyed, and you can really follow them over time until at 60 minutes after treatment, you can again clearly see hemorrhage, and especially a lot of small vessels got destroyed. So the green signal was almost gone. And also this is shown in the quantification. First, the signal of hemoglobin, which decreased over time in the high and low frequencies. And in comparison to that, the quantification of vessel fragments increased over time due to the breakage of vessels and having smaller fragments. We then followed this treatment over a much longer period of time, so not just for 1 hour, but up to 5 days after treatment, so long-term effects. And what we could detect here was extremely interesting. So at 1 hour after therapy, as I mentioned before, again, you see hemorrhage and single vessels that got already occluded. But then at 24 hours after therapy, we could detect a reperfusion of ischemic tissue. So tissue that had no vessels or no visible vessels before showed a very nice vascularization at 24 hours after therapy, which points out to a vascular normalization and this ischemic reperfusion of tissue. And then at 48 hours, without doing another treatment setup, the whole vasculature collapsed, and at 5 days after treatment, you could barely see any, or this was just necrotic tissue, which you could see here. And also here again, the quantification, so the vascular area first increased for 1 hour after treatment, and then decreased due to the collapse of the vessels. And the vessel fragments, same here, it first increased because you had some breakage of vessels, and then it decreased because of the breakdown of the vessels. So especially this at 24 hours, the reperfusion is a very interesting finding that we had, because this opening of alternative blood sources would allow also to come in with a second treatment approach at this time point. So it's very good to know when is this actually happen, and then you could apply a second treatment or repeat the photodynamic therapy again, because now you can access vessels which you couldn't access before. Of course, we also confirmed these results with histological examinations. And as you see here, so in the upper 2 rows is the H&E staining to show just the structure of the tumor tissue. And it could be detected that the tumor tissue and also the vessels, as you see in the second lowest row with the CD31 staining, got really destroyed already at 1 hour after therapy, and vessels almost disappeared at 24 hours after treatment. While on the other hand, you see much more apoptotic and necrotic cells, as you see in the lower row with the tunnel staining. So after 5 days, there were no vessels apparent anymore, and also no viable tumor tissue. We then thought of using a second wavelength in the RSOM to monitor also blood oxygenation changes in the tissue. So in addition to 532 nanometer, we added a laser with 515 nanometers. And as you can see in the absorbance spectra, at 515 nanometer, deoxyhemoglobin has a stronger absorbance compared to oxyhemoglobin, and at 532 nanometer, it's the other way around. Then oxyhemoglobin shows a stronger absorbance. And if you use these 2 wavelengths, you can calculate a ratio out of the signals which you get at these 2 wavelengths, and calculate for a gradient of oxygenated hemoglobin. We then applied the same treatment to also again CD26 colon carcinoma tumors. And as you see here in the images, in the upper row is the oxygenation images. So the more red it is, the more oxygenated hemoglobin is in the tumors. And what you can see is that compared to before treatment, at 5 minutes after therapy, you have a strong reperfusion of oxygenated hemoglobin into the tumor tissue, and afterwards it decreases and you have more deoxygenated hemoglobin. So this reperfusion of oxygenated hemoglobin points again out this reperfusion of the tissue and also the destruction of tumor blood vessels. In the lower row, you can see just the hemoglobin signal, which also shows the breakdown of the vasculature over time and the rather necrotic tissue at 24 hours after therapy. And then, of course, in the quantification of the oxygenation inside of the tumor, you can also see that it first increased in oxygenation, and then up to 24 hours after therapy, it decreased. So we could detect with RSOM time-resolved oxygenation changes after vascular-targeted therapy. Following these mechanisms that we could already detect after therapy, we then thought of looking into tumor models, which were bladder tumor models, which had actually a different response rate to this vascular-targeted therapy. So there was this group at MSKCC, it's a Coleman lab, which had two tumor models. First, 5637, which is very sensitive to vascular-targeted photodynamic therapy. And as you see in the graph of the tumor volume, they always had a 100% response. So all tumors got destroyed with this treatment modality. In comparison to that, these UMUC3 tumors were rather non-sensitive to this therapy and only showed a 30% response rate, and a lot of tumors grew back. So the question was then, what makes the difference in this treatment response between these tumor models? And there were a lot of studies of trying out multiple treatments or also some genomic analysis of these cells or tumors, but none of these really gave an answer to this question. So we thought maybe it could be related to the vasculature within the tumor. So we tried to use RSOM to see difference in the tumor vasculature of these two models and maybe get an idea why they respond so differently. And then we discovered great effects which really distinguished responders from non-responders. So as you see here in the images, on the upper row are the responding tumors and in the lower row, the non-responding ones. And as you can see in the upper row, the 5637 tumors, they showed a very similar behavior than the CD26 tumors, which I showed before. So they showed some vessel breakdown, but then at 24 hours, they showed a reperfusion of the tissue which was ischemic before, and then they completely collapsed. So all the vessels were gone at 14 days after treatment. In comparison to that, the UMUC3 tumors, which didn't respond very well, they did not show this ischemic reperfusion at 24 hours after treatment, but rather a constant kind of breakdown of the vessels. But then at 3 days after treatment, they only showed a necrotic tumor core, but the surrounding of the tumor started to grow vessels again. So a huge amount of neoangiogenesis, especially at 14 days after treatment. And this, of course, was also shown in the tumor volume. As you see in the graphs, the responsive ones were all treated, while the non-responders were growing back. So with analyzing this, we could also, or quantifying it, there was a huge difference also. The responders showed first an increase in vascular area and then decreased. In comparison to that, the non-responders showed a constant increase in vascular area throughout the whole imaging period. When looking at vessel fragments, there was also a difference. the 5637 tumors increased in vessel fragments up to 1 hour after treatment, and then decreased because of the collapse of the vessels. Compared to that, the UMUC3 tumors showed a steady increase of vessel fragments due to the neovascularization which happened after treatment. And we then thought to find a parameter which really distinguishes responders from non-responders at a certain point in time. And the parameter we found was the ratio of hemoglobin in the green channel, meaning in the high frequencies, so the small vessels, to the vascular area in the whole tumor. And already at 3 days after treatment, the responders showed a much higher ratio here than the non-responders, which also stayed significantly different at 7 and 14 days after treatment. So very early on, we could clearly differentiate responders from non-responders using RSOM imaging. And this was much earlier than we could actually really detect changes in the tumor volume. And also for this experiment, we confirmed everything, of course, with histology. And as you see on the top are the 5637 responders. And you can see a destruction of the tumor tissue over time, up to 14 days after treatment, and also a loss of blood vessels in the CD31 staining of the vessels. And in comparison to that, the non-responders, UMUC3, they showed a regrow of only slightly deteriorated tumor tissue, and also you could detect blood vessels throughout the whole period of time. Some other imaging areas which we also explored, I thought it would be nice to give a little overview of what else is possible with RSOM. It's not just imaging tumors over time or the response to treatment, but for the future, it might also be possible to image orthotopic tumors. And as an example for that, we imaged a brain and its vasculature. So this is actually a brain after opening the skull, and you can nicely see the vessels. So on the top, you see, like you're looking from the top onto the brain, and then the lower image shows the view from the side. With a closed skull, you can also see a few vessels, but not as many as these, but bigger vessels are even visible when it's still closed. Another example is imaging the mouse and the food pad of a mouse. This was an example from a paper we published 2 years ago, or now it's 3 years ago already, after injecting a dye into the food pad. So you can clearly see the vessels in the food with and without injecting the dye. And this could be used, some models use, for example, melanoma tumors injected in the food pad of the mouse. And of course, it's also possible to image agarose phantoms with RSOM and different dyes, for example. But these agarose phantoms, of course, are very, very small in size, so only like 10 microliter per droplet. Just to give you an idea what else is also possible. And with this, I actually already want to conclude from my talk. So we gained unprecedented insights into the mechanisms behind vascular-targeted photodynamic therapy using RSOM imaging. We could not only show the destruction of tumor blood vessels, but also time-resolved oxygenation changes and ischemic reperfusion of tissue, which gives a lot of insights and might improve the way how we actually use this treatment, especially in preclinical research. These non-invasive high-resolution images facilitated detailed aspects of dynamic, morphological, and functional responses to novel vascular-targeted therapies. So just to mention that, it's not only possible to image photodynamic therapy, but also other vascular-targeted therapies or anti-angiogenic therapies. All of these would also be feasible with RSOM, and to image this over time and to study the effects, especially on the tumor vascularization. RSOM can furthermore predict treatment response of different tumor models based on their vascular pattern, and this very, very early on, as we could see. And these results potentially lead to an improved treatment for different tumor models and also for very early treatment outcome predictions. I thought I also show this image here. We are very proud of this. After the paper got accepted, we also got onto the cover of Nature Biomedical Engineering with RSOM imaging. So this is currently also online, and this shows a tumor in a more artsy way with blood vessels around and getting illuminated with laser light and emitting ultrasound waves through the tissue. And last but not least, I want to thank all the people that were involved in this study. First, of course, the Jan Grimm lab from New York MSKCC, where I was 3 years, and then with Camila Longo Machado. She was a postdoc in the lab, is now back in Brazil, but has a huge knowledge on all cellular mechanisms within the tumor, and Dr. Magdalena Skubal, who helped with the brain imaging. And then, of course, the people from Munich, Vasilis Nitschakistos, Murat Umar, and Andrei Bereshnoi, with their engineering background, they could help a lot in setting up the system and doing the dual wavelength RSOM imaging. And then the Reiner lab with Thomas Reiner and Christian Brandt, who were involved mainly in these phantom imaging and food pad injections. And then also Dr. Cheryl Roberts, who helped a lot also with the brain imaging. And the people from Weizmann Institute, Avigdor Scherzli-Lach, they have great expertise with this vascular-targeted therapy. And then the Coleman lab, also with Guang He and Ricardo and Karan, and they were of huge help for this model of bladder tumors and the tumor prediction using RSOM. And then, of course, iThera, who followed me throughout these years to give their input and help. And then with this, I want to close, and I want to thank all of you for taking your time and listening to this webinar and having that great interest in this topic. And I'm happy to answer your questions if you have any.
So thank you very much, Katja. We have got questions coming in, so I'll just collate these. And while you read those and think of answers, I just want to talk for a minute or two about RSOM. I just wanted to mention that the RSOM is a technology that we developed at iThera Medical. We designed this for both clinical and preclinical use. Obviously, two different systems. The clinical system has a free laser source that you position on the surface of the patient, and this is really designed for imaging skin and underlying vasculature, while the Explorer P50 is the preclinical version of the system that we designed with a little light-tight animal bed so that you can do the sort of work that Katja has just presented on. Both of these systems are available as a single wavelength, 532 nanometer laser system, or a multispectral system. From a general point of view, you can image up to 12 millimeters square area with these systems to a depth of about 2 millimeters. The resolution is at best 10 micron in the axial resolution, and it takes about 60 seconds to image the field of view per wavelength. For the multispectral system, we do have 4 wavelengths available so that you can look at oxy and deoxyhemoglobin as well as melanin, and you can look at 532, 555, 579, and 606 nanometers. For those interested, the laser repetition rate is about 1.5 kilohertz, so it's a very fast laser. It's centered at 50 megahertz. However, it's unique in that it has a greater than 100% frequency bandwidth. So as Katja has described, we pick up very low frequency sounds from large vessels and high frequency sounds from very small vessels. So thank you for attending. I'll get to the questions in a second, but obviously if you want to know more about the technology, please do contact us and to discuss how this may relate to your applications. And while we do technically offer RSOM demos, with the ongoing situation with COVID-19, we're unlikely to be able to do this for a considerable period of time. But in the meantime, if you do wish to consider RSOM as suitable in your research, please feel free to contact us and we can always help you with technical data or discuss the potential grant applications. So thank you for your time here. We'll now move on to questions. So I'll open up to Katja. Has motion correction been applied to any of the images that you showed?
So in the images that I showed, we did not use motion correction. Nowadays, it's possible to do this in the software, but we had a very preliminary version of the software, which was kind of homemade just for us, and we didn't have the motion correction algorithms. But as we put this thin foil onto the tumor tissue, we actually had no issues with motion in our imaging process.
Okay, next question. Which tumor model, the responder or the non-responders, have more hypoxia after VTP treatment?
Yeah, so we didn't really look into that, but this is would be a very good topic to follow up and to really check for oxygenation in these two tumor models. But back then we only had a single wavelength laser for these two tumor models, so we couldn't look into the oxygenation, but it's a very interesting question to ask.
And is it possible to discriminate vessels from the tumor or those from the skin?
Yes, it's possible. So especially if you look into the tumor growing over time, because you see some vessels are already there and then some just develop after you implant the tumor. So based on that, from before and after growing, you can distinguish that. But also when you look at the images and you look through the layer of the images, so you get a 3D image and you look through it, you can also distinguish skin from tumor just by looking at the image. Yes.
Okay. Did you observe any vessel or hypoxia cycling in any of the tumors?
We did not, but just because we didn't look into that. So we mainly focused here on treatment monitoring. So as you could see, this treatment happened very, very fast. So already at 5 minutes after applying photodynamic therapy, a lot of vessels got destroyed and the whole image changed. So we couldn't really see that here. And we also did not focus on studying this vessel cycling. But as far as I understood from other groups, they could see this already using RSOM imaging. So it's definitely possible to see it. We just didn't look at it here in this study.
Okay. How did you quantify the total blood volume using RSOM? And then another similar question is, how are the vessel fragments calculated?
So for each image that you generate, you basically get a 3D image with single image layers throughout a stack. So for every 4 micrometer depth, you have another image. So you can use this image and just basically quantify whatever comes to your mind for this application. And for calculating blood volume, you would apply a certain threshold to the images to only count the amount of pixels, let's say, that exceed a certain signal intensity. And then you summarize them and add them up. And as you know how big is each pixel, you can then calculate the blood volume. And for vessel fragments, it's basically also applying a threshold to include only structures with high enough signal, and then count the numbers of these structures. And this can be automatized in image processing programs, for example, like ImageA or something. There are plugins which can easily do that.
Okay. A similar question for multispectral imaging is, why did you calculate the signal ratio of the two wavelengths rather than the multispectral signal?
With multispectral signal, I guess you mean not unmixing the signal. So if you just have two, if you just have two wavelengths, it's not possible really to do unmixing. So as we only had really these two, 515 and 532 nanometer, unmixing is rather difficult. And we decided to calculate the ratio out of this, just based on that we only have two wavelengths for this.
Okay, one question that's come up a fair few times now is, can the RSOM laser be used for PDT?
No, the RSOM laser cannot be used for PDT or vascular-targeted photodynamic therapy, because first, it's at 532 nanometer, or now for the commercially available systems, the highest one is 606 nanometer. And for most photosensitizers, you need 750 or 800 nanometer to activate them. And the second point is that the RSOM laser has a very, very low energy. It's about 20 to 80 microjoule per laser pulse. And the laser for applying photodynamic therapy has about 80 joule per square centimeter. So it's 1,000 times stronger than the RSOM laser. So it would not be enough to activate the compound.
Okay, so in that vein, can you use RSOM for imaging of contrast agents or nanoparticles?
Basically, yes, you can do that. You can image contrast agents or nanoparticles. First, they have to absorb in the right range of light, so at 532 nanometer, and then they have to have a very, very strong absorbance. So these regular fluorescent dyes that are available can only be seen in phantoms and at very, very high concentration, but not after injecting them into an animal. You would just need too much of it. And for some nanoparticles, you can really in phantoms see single nanoparticles. Same, for example, for melanoma cells, because they have a lot of melanin and absorb a lot of light. However, this needs to be tested for each and every kind of nanoparticle, and also injecting them into an animal or under the skin is rather difficult then to detect, just because the light absorbance by blood is so high that you can barely see them if they are not in a very high concentration.
No, brilliant. So there are a fair few questions still left to answer. However, what I think we'll do is answer those via email, given the progression of time here. So I just wanted to say thank you very much to everybody for attending. As mentioned, we will send the recording of this to you, as well as posting it on YouTube. And once again, thank you. And as it's Thursday, I suppose, enjoy your weekends.